Okay, all right. So I appreciate everybody for taking their time out of their day to log into this webinar. I certainly know that everyone's time is valuable, so certainly appreciate your time. So today, the title of my talk is Improving Lung Cancer Survival in the Community Setting, Nodule Management, Screening, and Program Development. Basically, what I want to do today is explain the program that we built in Western North Carolina. So this is a map of the state of North Carolina with all the counties of North Carolina. What is circled in red is essentially our practice, our geographic region. That is the Blue Ridge Mountains / Smoky Mountains, a very rural area of North Carolina. The largest city in Western North Carolina, many of you know, is Asheville, North Carolina, which is located in Buncombe County. My practice is located in Haywood County, which the little red and black star is where I'm located. So everyone knows that lung cancer is not a good thing. It's the #1 cause of cancer-related death in the United States, and it kills more people each year than breast, prostate, colon, and pancreatic cancers combined. We're starting, our population is aging. We're starting to see, and we're seeing more lung cancer as a result of that. Unfortunately, nationwide, we continue to diagnose more stage 3 or 4 lung cancer than stage 1 or 2. And unfortunately, this carries a very poor 5-year survival rate. So a very true statement that Dr. Carbone stated. He stated, at present, lung cancer is recognized late. Opportunities to improve survival are through earlier detection, accurate diagnosis, accurate localization, and curative therapy. Now, unfortunately, this wasn't just said 2 years ago. This was said nearly 50 years ago, and it has remained true for almost 50 years. It's only in the last few years that we've really started to move the needle on diagnosing these cancers early. So, because we know if we can diagnose these cancers early, the 10-year survival of stage 1 is 88, 90%, versus we know it's bad at stage 3 or 4. So the question is, how do we get from the current state, which is 85% or so of our cancers are being diagnosed at stage 3 or 4, to the ideal state, which it would be great if 85% of our cancers were diagnosed at stage 1 or 2. So that's the task, is to move from current state to ideal state in lung cancer. So, well, we already know that there was a trial in 2011, the National Lung Screening Trial, that taught us a few things. So the first thing it taught us is, well, hey, if we screen our patients for lung cancer, 70% of what we're finding that ends up being cancer is early stage lung cancer. And we only need to do about 320 scans to save one life with lung cancer, which represents a 20% decrease in mortality. And according to the people that run the numbers on this, it's actually cost effective to screen our patients for lung cancer. $81,000 per quality adjusted year in comparison with no screening. So I guess the bar is it has to be less than $100,000 per the experts in order for a screening study to make sense. And so this compares very favorably to mammograms and colonoscopies. So has this happened in the United States? So in 2013, the U.S. Preventative Service Task Force updated their guidelines recommending yearly screening for lung cancer. Medicare and insurance has approved this test. And I don't think anybody's going to argue that detecting lung cancer early is not important. And I don't think anybody's going to argue the importance of managing our incidental pulmonary nodules. So that being said, what has happened? Well, unfortunately, fewer than 4% of our high-risk patients actually get screened. So this study published in JAMA Oncology in 2017 kind of looked at before the guidelines, the USPSTF guidelines in 2013 were released, and after. So before, in 2010, they found that 3.3% of high-risk smokers were screened in the previous year. So then the guidelines came out in 2013, and in 2015, only 3.9%. So it really didn't change, which in actual numbers, of the 6.8 million current and former smokers that were eligible for screening, only 262,700 people were actually screened. So certainly much worse than we should be doing. So the two questions really are, why is the rate of screening high-risk patients so low? I mean, after all, this is an evidence-based, guideline-recommended, and Medicare-approved test. The second question is, what can be done to change this? So the first group I want to look at is providers, right? And then we're going to also look at the patients and kind of try to figure this out. So taking a look at the providers, why is the screening rate so low? So a study published in Cancer in 2016 looked at the knowledge and attitudes of family physicians using low-dose CT for lung cancer screening. Now, most of the providers felt that, in fact, 98% felt that it increased the odds of detecting the cancer early. True. 75% felt that the benefits outweighed the harm, and 76% thought that the risk-benefit or discussed risks and benefits with their patients in some capacity. However, they felt really good about it, but more than half made 0 or 1 screening recommendation in the prior year to the study being performed. So furthermore, there was a study performed that looked at primary care providers in an academic medical center. So interestingly, this study was conducted at one of the centers that participated in the NLST trial. So this found that few primary care physicians ordered lung cancer screening. Of the ones that did, more actually ordered x-rays than CT scans, and some actually ordered sputum cytology. Less than 50% of primary care physicians could identify 3 or more of the 6 guideline components for screening, and a quarter of them knew 0. So certainly what this identified is there's a definite knowledge gap. And one of the things with lung cancer is a fatalistic attitude of lung cancer with providers and patients. So despite the data and despite providers feeling positive that we could find these early, 30% of the providers doubted the effectiveness of screening and improving outcomes. So yeah, we can find them early, but we're not going to be able to do anything about it once we find it or actually improve our patients' ability to survive their lung cancer. So what are the factors associated with CT screening utilization? So certainly the lack of knowledge leads to a lot of inappropriate referral rates from 2000, in our practices. So in this study from 2013 to 2015, 37% of the low-dose CT scans that were ordered were inappropriate. Well, I think this is a problem for a few things. Number one, the more difficult it is for a provider to order a test, the less likely they are going to try to order another one down the road. So I think that leads to less tests being ordered and ultimately less patients being screened. And the other thing that was found in this study is that the majority of providers are unsure whether this is actually covered by Medicare. The good news, though, is that most providers want to learn more about lung cancer screening. So what has been learned with providers? So number one, there's a documented disconnect that's well established in literature of moving clinical research findings into clinical practice. Probably the best known example of this is the 1981 beta blocker heart attack trial that took decades to find its way into practice. So again, the low-dose CT scan for screening, this is an evidence-based, guideline-recommended, Medicare-covered test, but it's not yet made its way into routine practice. Physician knowledge is not optimal. We know that. There's a physician belief that low-dose CT is valuable for early detection, but less believe that it actually makes a difference in mortality, so a fatalistic belief. And a lot of physicians believe that it's less beneficial than other screenings, mammograms, colonoscopies, etc. So shifting to patients. So that was providers. Now, why do patients adhere to screening? So most patients, 60% of patients in this study, if their provider recommends a screen, they'll show up to the screen. Turns out that the younger you are, if you're white and if you're female, you'll have a trend towards better adherence. There's actually no difference regardless of cancer history, residential area, level of education, insurance, occupation, provider, location. Now, the ones that did not adhere, so most of those patients, 79%, said, hey, I'm not going to do it now, but I'll do it in the future at some point. That leaves 21% that just got an order for it, but decided they didn't want to go through with it. And if you look at why that is, well, there's once again, that fatalistic belief in cancer. Well, I have cancer. There's nothing that can be done for it. So why even find out about it? Fear of radiation exposure, anxiety related to CT scans. Very interesting, I find, is if you look at the smokers. So if you have somebody that quit smoking or smokes less than they previously did, they're much more likely to show up for that screening scan. And this is very consistent with the data that smokers are less likely to seek out care for lung cancer. So I find that data very fascinating. And it really drives home the point that our smoking cessation programs need to be more effective. So what can be done to improve the screening rate? Well, number one, provider education. So fortunately, 82% were more interested in learning about low-dose CT scan. Now, in this survey, 59% would prefer an online lecture, lasting up to 30 minutes. It's suggested that the focus should be on mortality reduction and CMS coverage. And then also there's data on in-office decision aids, which I'll show you what we're using in our practice in just a second. And then secondly, patient education. So once again, the decision aids. There's data that if patients are empowered to have the information to have this discussion with their provider, they're much more likely to adhere to screening and have this ordered. And then community outreach and advocacy. All right, so there was a study, getting back to decision aids, performed in Asia, which said providers who discussed the benefits of low-dose CT scan screening with the use of shared decision aids increased screening participation from 10 to 95%. Well, I think that's certainly a huge number, and I don't think they're that effective, but nonetheless, I do think they're effective, and we've seen that in our practice. All right, so I'm going to shift gears to the incidental pulmonary nodule clinic, and then before I get into our data. So I was fortunate enough to be involved in what I believe is the first system-wide incidental nodule program in the country in 2013. At that time, I was working with Dr. Jennifer Mattingly, who certainly deserves the vast amount of the credit for this program, but we certainly worked together on this. And the reason we did is because there's an institution-driven initiative to do this program, because we knew that patients are falling through the crack and there was a medical legal risk. So we were tasked, and again, I'm giving Dr. Mattingly the credit for this, of doing a retrospective chart review where we reviewed nearly 1,000 patients' charts to see what happened if a pulmonary nodule was found incidentally. So what we found is pretty sobering. We found that only 19% of patients were followed appropriately. 20% of patients were actually unacknowledged. So the radiology report came out, and there was never a mention again in the patient's chart that this study was ever done. 18% were referred to pulmonary, but some of these patients never showed up in pulmonary. Some of them showed up in pulmonary, didn't adhere to further CT scan recommendations. 19% were outside patients, so we weren't able to find out what happened to them. And then 24% were acknowledged, but at risk for loss of follow-up. So those patients, their primary care physicians discussed these findings with them, but then they never had the CT scan or they never followed up with it again. So what did our clinic look like? So what our clinic looked like is it started with the radiology report that had a pulmonary nodule. Now, one of the hardest things initially in setting up this program is we had to ask radiology to change their workflow. So I'm going to just skip to the next slide and then come back. But what we asked radiology to do is to change their report. And we asked them to put several things on it so we could risk stratify our patients essentially and put them into high, moderate, and low risk categories and make sure that they're receiving appropriate care. So this took a lot of work and a lot of meetings and then to get radiology to adhere to this and to do this. But once this was done, we're able to start our lung nodule clinic. And so the radiology would report this. It would then come to the nurse navigator who reviewed the report, calculated the patient's risk, contacted the patient. The navigator then facilitated an appointment with either a pulmonologist or a primary care physician, depending on risk factors. The pulmonary provider evaluates the patient. Patient undergoes appropriate testing. Data is entered into the database. Navigator ensures then appropriate follow-up and that the patient's moving through the process. And then lastly, reporting of quality data. So what did we find? So this clinic began in August 5th, 2013. To date, greater than 4,000 patients identified and entered into the pulmonary nodule database. On average, 164 new pulmonary cases per month, which 57% of those were deemed high risk. So the point here is this data can become overwhelming because it's 164 patients on top of 164 patients on top of 164 patients, and that just adds. So early on when we were trying to do things with a spreadsheet and then homegrown software, it became very difficult to manage these patients. So getting into our program. So what did we do now in Haywood County? So Haywood Regional Medical Center. So we sat down and our overall program goal was, number one, improve lung cancer survival in Western North Carolina. So that was our one and only goal, and everything that we did had to help us reach this goal. So there's several components to our program, and I think several components that make any program. So lung cancer screening and pulmonary nodule clinic, of course, which we're talking about today. But in order, I think, to have a good quality program, you have to be able to do something with these nodules. So advanced diagnostics and therapeutics, multidisciplinary lung cancer team, quality improvements. So we're constantly looking at our stage shift, diagnostic yield from our procedures, adherence to low-dose CT scan, time to treatment, etc. Awareness and advocacy, and lastly, a smoking cessation program as part of this comprehensive program. So we knew as we were building this, we needed to reach the physicians that were going to refer to us. So over the past couple of years, we were able to visit the vast majority of the urgent cares and primary care physician practices in Western North Carolina. So this is just all the counties in far Western North Carolina. Again, our practice is, the hospital is right here in Haywood County, the blue one right in the middle. The stars all represent individual practices that I visited in the last 2 years. So generally these were breakfast meetings or lunch meetings to discuss nodule management, the lung cancer program, advanced diagnostics and therapeutics, essentially to meet these people and let them know what we're doing. We also had to raise awareness in the community. So in the past couple of years, we've, as a program, have written several newspaper articles for our local newspapers describing what we're doing, raising awareness, patient advocacy. Anytime we had the opportunity to get on local television in Asheville, we took that opportunity to talk about lung cancer screening, advanced diagnostic programs that we've done, community events. We've been partnering with Lung Cancer Alliance for the past few years to run a Shine a Light program in Western North Carolina. Other things that we do at Haywood Regional Medical Center are talk with the docs, an evening dinner, discussion and which is various topics, but certainly lung cancer and what we're doing with lung cancer at Haywood Regional has been one of those topics. And then lastly, shared decision-making materials. So I think this is a really important thing. This pamphlet now, as of this past summer, sits in every primary care physician's office in our network, as well as my office. And it allows the patient, as they're sitting there waiting for the doctor to come in for an appointment, to grab this pamphlet and read through it, and then have a thoughtful conversation with the provider. Secondly, it does a second thing. So the criteria for screening are listed right in this. So what I believe it does is it decreases the inappropriate referrals because the criteria are sitting right in this pamphlet. So I think this is definitely a key piece of having patients that actually adhere to screening. The number two, screens that are sent in that are appropriate screens. So what does our data look like? So looking at 2016 when we started our screening program to 2017. So in 2016, we did 96 total screens. Of that, we've diagnosed 2 cancers. In 2017, we did 269 total screens. Of that, we've diagnosed 3 cancers. So about what you'd expect from the NLST data, or from the screening data, excuse me. Maybe just a tiny bit higher than that, but of course we are certainly, my practice resides in the tobacco belt. There is a higher incidence of lung cancer where I practice. So looking at the same data on a month by month. So this is on the bottom, on the x-axis is January to December. So those are the months. On the y-axis is number of screenings done per month. And then the 2 years are side by side. So the blue ones are 2016 and the green ones are 2017. So when we started our program, we had everything ready to go. And in January of 2016, and one patient got scanned. And this could be one of the things that really makes people lose enthusiasm for a screening program, is you put all this work into it and then you're not screening anybody. But as time went on, we started to see more and more patients. But then as we did more outreach, more provider education. As we move into 2017, you see that the numbers month to month have increased. And then in this July of 2017, which is here, you see a significant increase. That has stayed increased. And looking at our data, and the reason for that is just the process that we had as far as scheduling these CT scans. We made it a much more efficient process. And so that one change that we made in efficiency increased adherence to this program significantly with our patients. So the incidental pulmonary nodule clinic. Now, in 2017, the total reports that were flagged were 125. Of that, we diagnosed from these flagged 20 cancers. In 2018, we went live with LungDirect. The first 2 months, 51 incidental nodules were flagged. Of that, we diagnosed 7 lung cancers. So if this continues for the rest of the year, that's going to be over 300 patients. So the question is, why is that? Right? I put up on the right-hand side of the screen the data from Dr. Mattingly and myself as far as what are the possibilities. This has nothing to do, of course, with what we found in Haywood, but I think a lot of these, I think are not, I think there's a lot, probably more than 19% have been followed appropriately, but there's some that are unacknowledged, it's read by the radiologist, unacknowledged. We had to rely on these being flagged by radiologists, from the radiologist put into a basket that was then, the navigator had to then go retrieve from the basket. And so you had all these different human interactions that I think led to a decrease in the number of flagged reports that ended up in the navigators in basket. So fast forward to 2018, we're seeing a lot less of this. As a result, we're capturing much more of our incidental nodules. So what does this mean, though? So, before we started the program to after, because what we really want to know is what are we doing to increase patient survival with lung cancer? So pre-program starting, we 20% of our patients are stage 1 and 2. So very consistent with national data that most of our patients are stage 3 and 4, that in a much smaller number of cancers. After our program started, we saw a significant stage shift. So now 56% of our patients are stage 1 and 2. Furthermore, looking at all of our patients in 2017 that were diagnosed with non-small cell lung cancer, 54% of these went on to either get surgical resection or stereotactic radiosurgery. As a result of this work, we were fortunate enough as a hospital to receive the 15th community hospital in the nation to receive the Bonnie J. Dario Foundation Community Center of Excellence designation. And this is certainly a good time to make sure that everyone realizes that this is a team effort, and this could never be done without excellent radiology and administrative support in radiology, overall administrative support, an upfront navigator in the navigator team, pathology, as well as the medical oncology, radiation oncology, thoracic surgery, and then of course pulmonary. So it's certainly a team approach. So what have we learned? So number one, an incidental nodule program grows exponentially, and if you're trying to use spreadsheets to manage this, it's nearly impossible because the it just keeps on growing and growing and growing. Having a front-end navigator is essential. So in our program, we're a small hospital, but we've split the duties. So we have a front-end navigator that works before cancer diagnosis, up to cancer diagnosis. Actually, she's actually my procedural assistant as well. And then we have an after diagnosis navigator. So Amanda beforehand, and then Johanna after. And this is essential, I think, to for sure have somebody that's dedicated to the front end because this workload grows. We've learned in my previous practice as well as now that an incidental nodule program that relies on human input is going to miss patients. And also, I think it's very difficult to build these programs without the appropriate people involved. So a physician champion, I think, is essential. It does not have to be a pulmonologist. It certainly could be. It doesn't even have to be a physician. I think that this could be an administrative champion in certain places. You need a navigator, administrative support, radiology support, because you're asking radiology potentially to make some changes. Now with with this has become minimized or actually has become non-existent with the software programs of LungDirect. but that was certainly always the case. And then there's strength in numbers. No hospital can do it all by themselves. So we've partnered with other organizations to improve patient care and access. The Bonnie Dario Foundation, North Carolina Lung Cancer Initiative, Lung Cancer Alliance. What else have we learned? Education of providers and community outreach is important and works. We've seen our numbers improve. We've seen the amount of referrals for lung cancer screening increase as a result, I believe, of doing this. The physician aides, the patient, the visual aids, I believe also help that. Submissions to the ACR are difficult for low-dose CT screenings, and they're cumbersome. So I think this has been well described in the literature as well. These get kicked back all the time. If you miss one thing in them, they get kicked back. And so I think a much more efficient way to submit these is automation. And so we've certainly learned that the hard way as well. Scheduling, screening low-dose CTs is more time-consuming. When we saw our bump in low-dose CT screens in July of 2017, it was a direct result of changes that were made in the scheduling process. And the thing that we continue to struggle with as a program is smoking cessation. It's certainly the biggest challenge that remains in our program. We've tried multiple different things, and we're still looking to build a very successful smoking cessation program. But this is definitely, has been one of our biggest challenges. So this is a picture of, the Blue Ridge Mountains, and where I believe Haywood Regional Medical Center may be located. I just took a guess there, but this is what it looks like where I live, and fortunate enough to practice there and call this my home here. But that is what I have to say. I'd like to open it up for questions.
So guys, on the right-hand side, let's see real quick. I'm going to stop this. And then you can raise your hand on the right-hand side, and then we can know that you have a question. Or you can type into the chat and just type your question on the right-hand side of the chat. I did see that one person did have a question, and I think it was James that I saw. Let's see here. If you raise your hand again, I can take you off of mute, and we can get you to have. Here we go. James, you're on. What's your question? Hey, James, how you doing? Let's see if I can unmute you. Sorry, we had actually so many people that were on this that we had to get a new webinar. Let's go here. All right, so I have some questions, and then we'll allow, here we go. Do you have any issues with the radiologist recommending a 6-month follow-up screening LDCT? So this is from Jane Fry. Hi, Jane, how you doing? The number of screenings done in 2016. So let's talk about Jane's question first. Do you have issues with the radiologist recommending a 6-month follow-up screening LDCT?
No, in a negative or lung RADS 1, we have not. So our radiologists are excellent at adhering to the current guidelines of annual screening.
Yes, and so just to be kind of clear, and this may be the common knowledge, but a lung RADS 1 and 2 get a 12-month annual CT scan, and then a lung RADS 3 would have a 6-month follow-up. Anything that's not an annual, like if it's scheduled out in 12 months per the ACR, is considered a follow-up. So I don't know, if it doesn't matter if it's a 3 months, if it's a 4A, it's a 3-month follow-up that's recommended. If it's a lung RADS 3, it's a 6-month follow-up, and then lung RADS 2 and 1 are considered annual. And you don't use the word follow-up. I don't know if it makes sense or not, but it's just language. Right. And then let's see here. We have the number of screens done in 2016 and 17. Were these all initial screens or a combination of the initial, annual, and 3 6-month follow-ups? So this person actually knows that language really well.
Yeah. So the vast majority were initial screens. So one of the problems, one of the struggles that we've had as a program is getting primary care physicians and our patients to adhere to that second follow-up screen with the lung RADS 1 or 2 screen. And so it certainly is going to add to our 2017 numbers without question, but it's a relatively small percentage. So one of our initiatives moving forward is going to be better adherence to follow-up screens.
So Jordan, it does look like it was probably a combination, and there is a huge amount of drop off. And just so you know, the 90% of people who go into lung cancer screening will get an annual follow up. So in terms of the numbers, the majority of those patients were the annual follow up, and were likely not included in that aggregate number for that slide, I'm assuming.
Correct.
Right. And then like Dr. Skibo said too, there's this thing called risk of never follow up, and there's actually new data now that shows that if you're 30 days, so let's say you're scheduled for a 3-month follow-up and you haven't had that 3-month follow-up, the patient never came in for the CT scan, and it's 30 days past that 3 months, they're at risk of never follow-up, like huge risk of never following up. At 6 months, it's 45 days. And at 1 year, if they haven't had it within like 3 months of it being due, then the risk of never follow-up is greater than 90%. So really important to communicate with your patients within a window of when the actual follow-up or annual is due, and then when they don't come in. So normally most people wait, no more than 2 weeks to communicate that, hey, you missed your scan, and try to get them to come in for that annual 3-6 or other follow-ups. Let's see, the next question is from James Paramore. On one slide, there were 2 patients diagnosed in 1 year and 3 the next year, but multiple LRADs of 3 and 4. Okay, so I think this is asking a question about if you have a patient who's in the higher risk category, the higher pretest probability, why don't you have more cancers, right? I think that's the question. Is that how you're seeing that question? Or am I right, James? Is that what you're asking? Why is there not more cancers? I think that's what that's what it's asking.
Yeah, well, I think and I'd like to get your opinion on this too, Aki, but I think, you would expect, especially lung RADs 4, a lot of these end up being cancer. Certainly not all of them are. And some of these, the lung RADs 3 and 4, you could just are followed and end up being diagnosed with cancer in a time frame. But, the data is the data, I guess.
Well, here's the thing too, is that I think that, lung RADs 1, 2, 3, and 4, A, B, and X don't necessarily put a pretest probability on each of those nodules. And so you don't know, in terms of a lung RADs 3, I think that you would probably, we could get the real numbers of how many lung RADs 3s actually had cancer. And in this patient population, the rate of cancer is very, very low. If you look at the whole overall, anybody who's a lung RADs, 1 through 4, just because you're a lung RADs 3 or 4 doesn't mean that you should have, over 50% of those patients who actually get diagnosed with cancer. I think the lung cancer, like actual rates in 3 and 4 are quite low. And James, I'll get the real numbers on that, and we can send that to you. I'll get you the exact numbers of the lung RADs 3 and 4 that actually correlate to cancer in the NLST trial. So let's see. Hi, Dr. Skibo. Thanks for the great information. Excellent presentation. I agree. You mentioned change in process that increased lung cancer screening adherence. Can you say again what that change in process was? And we talked about this before, right. So go ahead.
Yeah, well, essentially, the biggest thing that occurred was one person took ownership for that. So I think it's very akin to if you have 2 pulmonologists and there's a big stack of pulmonary function tests to read and a big stack of cardiopulmonary X-ray stress tests to read, and they're both responsible for that day, the PFTs are going to get done first, right? So these scheduling these tests, the low-dose CT scans, is more cumbersome than scheduling just a regular CT scan. So there's a little bit more work to make sure that these are appropriately scheduled tests. And so because of that, I think it got put to the back burner at times. And so there was patient dissatisfaction because primary would send in an order and then it wouldn't get scheduled initially. And then we had, I think that's why we saw drop off. And as soon as that process was fixed, we saw much better adherence.
Intake's tough still. I think that, you got to think about it, that you got to have some sort of documentation that there was a shared decision visit, that there was smoking cessation, and that the patient meets inclusion criteria. And like you said, like I saw one of your slides earlier saying about how many screens were done on people who were actually ineligible. And there was new data that just, we were talking to Deb Dyer actually about this, and she's saying that it's probable that maybe up to 60% of patients who were screened may actually be ineligible, which is a huge number. I don't think we actually know the exact number, but I think that intake, centralizing the scheduling, these are things that we're still trying to figure out on a big scale.
I mean, just the study I cited in this talk was 37%. So it may be higher than that, but a large number without question.
So Heather Hewer asks, which type of reports were involved in identification of nodules? Were these just low-dose CT screens, or did they include all the other CT scans that you can think of?
Everything. Basically, anything that you'd see a nodule on was included in this. So essentially, that in which if there's a nodule, we want to know about it, right? Yep. And then we can work it up appropriately from there. But whether it is chest X-ray, whether it is an abdominal and CT that gets the lower lungs, whether it's a chest CT, whether it's a low-dose CT scan, we want to know about it. And so it essentially any study that has a nodule.
And Heather, just to expand on that, I've seen, I'm lucky enough to go around and see a lot of people's different shops and how they do things. And it's really the non-LD CT scans that need to be, that have to have those reports, because the low-dose CT scans usually are reported with the lung rads. And so that would let you, like the lung rads designation, you can pull that pretty easy. And you can track nodules that way for lung cancer screening patients. The big difficulty to me is trying to identify the patients who are not in the low-dose CT screening cohort. It's the incidental nodules. So you're right, the chest CTs, the 71250s, the CT angios, the CT abdomen pelvis, the CT necks, they go into the ER, they look for a blood clot. And so if you do a CTPE study, you're 2 times more likely to find a pulmonary nodule than you are a blood clot. And so those are the patients that really need these reports to be identified, because they're the ones who I think are really slipping through the cracks. So let's see, Rachel Lappel or Lapel. Hello, Rachel from Naval Medical Center in San Diego. Thank you for your service, first of all. And what is your process as far as reminder calls and letters to the patients?
Well, since we went Lung Direct, with Lung Direct, it's now all automated. And so I guess unless I let Aki answer this question much better than I can, but it's become an automated process, which I think is an essential piece of a program, because the workload becomes tremendous. As you follow these patients, you just gather patients. And so you have such a database of these patients that if it's not an automated system, things are going to get missed. And so, yeah, it's a completely automated process at this point.
Yeah, and that's getting better too. I think that what you can do is you can automate, and if you don't have software and just trying to do this on your own, I think that you template out different letters. And so you have a lung rads 1, lung rads 2, lung rads 3. You have an initial, you have a follow up, and then you have if they've missed, and you have it from the PCP and to the doctor, to the ordering physician and the patient. And so we have templates, and I can actually. Rachel, if I'm saying your name right, I hope I am, we can send you templates of letters that you can use for that process. And so, you don't have to have software to send letters and communicate. We can give you templates so that you can start that process. And our recommendation would be that you have multiple templates at your disposal that you can do based on the situation. So let's see, Karen Markle, any advice on how to convince the hospitals to fund a database that would help track the lung nodules and cancer screenings? I know this one, but you go ahead.
Well, you know it, you answer.
No, this has become my life, right? So
right.
I think both of us, have gone through a situation where it really, you're passionate about not having patients who had a CT scan and then they later show up with late stage cancer. And so I think that the importance of tracking lung nodules does take time. It takes FTEs, it takes effort and work. And so to me, it's really starting that program and tracking it on your own at first is how I did it personally at my previous practice. And then watching everything that happened downstream. And now we even have so now when we try to, help people get Lung Direct in, is that we do a pro forma. We have a generic pro forma that I can share with you, Karen, that can show, like, if you had this many lung cancer screens or if you had this many nodules, here's the revenue that's gonna be brought to the hospital. And that should help you get some resources, not just, funding the database, but funding the resources to really have a complete program that Dr. Skibo talked about. We ended up at my shop, they ended up getting a new SBRT machine, and like they hired a radiation oncologist and a thoracic surgeon, and because of the revenue that was generated straight from nodules.
Yep, I agree.
Yep. And then Jody, so I think that your question is, in our program here in Brooklyn, New York, we took out on the responsibility of scheduling patients for their annual screens. We contact them directly and then contact the referring MD for the order. I don't think that's abnormal, do you?
No.
Yeah, I think that's normal. I think that that's so. We had a talk last month about centralizing the scheduling, and to me, I think that's very smart. Just because of the same thing that you were talking about earlier.
Absolutely, I agree. With that, you increase adherence. Absolutely.
Roger Johnson. Hey, Roger, how you doing? Roger, I love Roger. So Scott, great talk. Good work in Western North Carolina. Can you tell us what you have done to streamline this? Everybody is trying to figure out the scheduling process.
Yeah, well again, this was answered previously, but again, it's having one person take ownership for this instead of just a big bucket of general work that everyone has to help out with. If one person has ownership for this process, it gets done, and that's what we found at our shop. Now, again, our system's not going to apply to everybody because, again, I know we're a small hospital, 159 bed hospital, but it works. If you give or a small team of people that this is one of their responsibilities, I think that certainly has helped us tremendously, and I think the data on our adherence to screening would support that.
And Roger, we can catch up too offline on some things that we can help you with on a systematic fashion too, with centralizing the scheduling. Amy Shea is an amazing nodule coordinator from the Medical Center of Aurora in Aurora, which is just outside of Denver. She is awesome. Sorry I was late to the call. What obstacles, of any, do you have with shared decision-making visit for the LDCT screening patients?
Well, that's a good question. I guess I don't really obstacles. I think the obstacles that we've tried to really overcome are, I think it all starts with the primary care physicians, and because they have more impact on preventative care than a pulmonologist ever will. So the obstacles that we have tried to overcome is an educational barrier, to an educational deficit, and our shared decision-making literature that we put in everyone's office, I think has certainly helped that because it's educated the patient as well as the provider.
You put that in the PCP's office?
PCP's office, so exam rooms. So that's in PCP's exam rooms.
Did you go there yourself and put it in their office?
No, I can't take credit for that. We have a great marketing and physician liaison thing that took care of all that. So I certainly will not take credit for doing that, but that was a great idea.
That's really a great idea. I haven't seen it.
Because again, then when patients are sitting there in the exam room, doctors often running a little bit late, they read through the literature that's in there. And one of the things they're going to read through is that it catches their eye, especially if they're a smoker. And I think that's been a really good tool to facilitate discussion and to make sure that patients are aware of the data behind screening.
So Heather, Jody, we would definitely send you the templates and the pro forma. Taj Hawkins is going to get back to you with that. Karen, you're most welcome. Roger, love you. And then here's from Kelsey Corey. I'm a nurse navigator. May I please get a copy of the templates as well? Absolutely. Did you say once the incidental nodule is identified, the navigator contacts the patient, or do they notify the physician first to order the scan? I found in the ER, I usually notify the PCP who is listed on the ER physician record.
So both are actually contacted, but we did, both and this was data from our, my practice in Wisconsin. So we did take it upon ourselves to contact the patient. We felt as a team that the patient, this is information they need to know. We felt that the more people that knew about this, the less likely it was to fall through the cracks. And, but we certainly knew the importance and realized the importance of making sure the primary care physician was in the loop and driving the ship.
So I have some questions, Scott.
Oh boy,
here we go. Right. there's been places that have wanted to set up a lung cancer screening program who don't have all of the components that you listed to succeed. And so what I'd like to know, and we actually have, we helped set up a system at a critical access hospital that was, really 0 beds. And so what I want to know is if somebody in some, who knows where, anywhere, wants to set up a lung cancer screening program, they don't have all of the components. Can they do it? Should they do it? And how can they do it?
I guess the way that I answer that is yes, because you have to start somewhere. And I think if you start with, all right, well, let's start following our incidental nodules and lung cancer screening. I think the necessary component is a nurse navigator. But let's say you don't have an advanced bronchoscopy, or you need a plan to do something with the findings that you find, right? And so if you get a lung RADS4 patient, or if you get something that's worrisome that needs a procedure done, what are you going to do with these patients? Because you will find those patients. And so going into it, you just have to make sure there's a plan of where these patients get sent if they can't be dealt with in the current setting. So as long as there's plans put in place, but then I think in my opinion, what would be found is that the business that you get from this, how busy you get doing this, it facilitates acquiring that other stuff. So I think you shouldn't have to wait till you have everything in place to start a program. I think starting a program helps you get everything in place.
So win-win.
Yeah, but in the meantime, though, you have to just make sure there's a plan of how you're going to manage these patients when you get positive findings.
Absolutely. I agree with that. So Heather would like to know, as a hospital that may have double to even triple of your incidental nodule volume, would you anticipate LungDirect being able to support that volume and see the success you have seen?
Well, that's a hard question for me to answer, knowing that I just work. I think that my personal knowledge is I know that LungDirect is in hospitals that are much bigger than mine. So Aki is going to answer that part of the question. But I think it's a very scalable thing. I think that it decreases the amount of work that a navigator needs to do significantly. So your FTEs that you need managing these nodules goes down. So if I doubled in size, would I need another navigator? Potentially. So would I need 2 software systems? No. So would I need 2 navigators now front end if I didn't do LungDirect? Probably. So it would be overwhelming at this point, even in my size hospital, to just have 1 front end navigator. So my guess is that LungDirect would have no problem regardless of the size, but I'm going to let Aki address that one.
Yeah, we're in like I said, a critical access hospital all the way up to the Cleveland Clinic, and who just expanded us out to all 7 sites. And so all 7 of those sites are bringing in all of the volume into one centralized LungDirect software system. And they went from, I think, 1 to 3 hours per patient per year down to 5 minutes per patient in terms of what they're doing for data entry and some of their navigation. So, you can handle volume, but it depends. You still have to have infrastructure and a plan, Heather. So I don't think that, and in terms of being successful, like Dr. Skibo, we talked about this, coming here, is that there's an approach, and like there's a human who, it's about a person, right? It's not about, I think, the software, just specifically the software. The software, it helps, it's a tool, but there has to be a person who's a champion. And I think that's why Dr. Skibo has seen the success that he's seen. It's that he's dedicated and focused to championing everything that needs to happen and getting past all the roadblocks and all the speed bumps that will occur inevitably during you trying to set up a nodule program. Wouldn't you agree?
I would definitely agree, but I do think there needs to be a champion, but it doesn't have to be a physician champion. I've seen a lot of course, most of my friends happen to be pulmonologists, it seems. So I've seen a lot of good models where pulmonologists are the physician champion, but I've also seen hospital systems where there's an administrator that's a champion. So it doesn't have to be a physician, and it doesn't have to be a pulmonologist. That just seems to be, in the nodule world, the most common physician champion, because the pulmonologist is often the person that is on the front end with the nodules.
And you make a good point. I mean, Amy Shea, that I was bringing up, she's running that program. over at TMCA, and they have a kind of like a hub and spoke type setup where there's a centralized kind of process. I think it's really just looking at your environment and then looking at what resources you have and then planning, right? And every environment is just a little bit different, and it's really just creating something that all of these patients, you segment them out into risk. You do the same repetitive behavior with all of your lung RAS 1, your lung RAS 2, your lung RAS 3. I have a question about this kind of like things that come up. Is that what if a patient is in the ER, has a nodule, and they're unassigned? There's no PCP assigned, right? Who do you contact then, and what do you do with the patients who don't have PCPs?
So that patient would automatically now get the navigator. Amanda would get notified, and that's something so right now in our system, I would default to seeing that patient, but we would work on getting that patient a PCP. So as a system, we would help arrange that.
Awesome.
But as a nodule management, we would definitely manage that nodule. We would just take that on.
Gotcha. So guys, if there's no more questions, I think that really, this has been great. I always learn something with these, and Dr. Skibo, really appreciate you coming down here to the advanced bronchoscopy course here at the Cleveland Clinic, Florida. Excellent information. If you guys would like the information that was presented here or a copy of this webinar, I know that Tajwan Hawkins is going to be your contact. Don't hesitate to reach out to us for anything that you need in terms of templates. If you need pro formas for your hospital, if you need general information on how to set up a program, I think that either one of us are more than happy to talk to you about on a one-to-one level if you're trying to do this. I think a lot of people are trying to do this. There's a lot of struggle. Dr. Skibo has been very successful. I feel like we know kind of what we're doing too, and would love to share any knowledge with you guys. So thank you guys so much for joining us, and we're going to go enjoy the sun a little bit, I think. What do you think, Scott?
That sounds good. Thank you, everyone.
Yep. All right, guys.